the synchrony with which the agonist and antagonist fire. So that is lost in an upper motor neuron lesion. Okay, and fatigue, that is a negative component. And one of the positive components of the upper motor neuron syndrome is spasticity. Along with it, you will get hyperreflexia, then release of the primitive reflexes, then spread of the reflexes. Everything you will get in this positive component. So your aim of management of spasticity is to reduce this hyper muscle overactivity with less side effects, and don't produce any increase in the negative components. Okay. So before knowing spasticity, you should know what is the normal pathophysiology of the motor control. So what is the normal pathophysiology of motor control? Then we will see what is abnormal spasticity. So for a normal motor function, you need first the integration of a sensory feedback. Then they should be able to control the reflex activity. And you should coordinate the volitional movement. So these are the three steps in a normal motor function: integration of sensory feedback, control of reflex activity, and coordinate volitional movement. So the controller, the brain should know where your muscles are, where your joints are, and what is the velocity with which the muscle is contracting. All information should be needed. So this is by a feedback. So feedback is at a cortical level, there is subcortical level, at a brainstem level, and at a lower level, at the motor unit level, there is the feedback. So by this feedback, the proper motor control is occurring. It's by a feedback system. So as you all know, the distal unit is the motor unit. So a motor unit, as you all know, it consists of an alpha motor neuron and the fibers, muscle fibers. So these muscle fibers will be different, number of muscle fibers will be different in different motor units according to the purpose and function of the motor unit. And the pattern, that is what is really different than recruitment and firing rate. So you know what is recruitment and firing rate. So motor unit, the recruitment is the number of motor units recruited. That means one motor unit will be firing at the rate of 5 Hz. Then when it is 5 Hz, another one will be recruited. At 10 Hz, another motor unit will be recruited. That is a typical recruitment pattern. And the firing rate, that is lost in an upper motor neuron lesion. So there are different types of motor units, the type 1 fibers and type 2 fibers. Type 1 is an oxidative red small, that is mainly involved in, they fatigue slowly, and they are mainly have a tonic baseline activity. So type 1 fibers are mainly the postural muscles, in the paraspinal muscles and the soleus and all. It's mainly the type 1. And type 2 is a large fiber, large white and anaerobic, and they fatigue easily. So these are the power generating muscles that is used for weightlifting, running, they need more power and velocity. These are the type 2 fibers. And there is a mixed type of type 1 and type 2. So how the normal regulation of motor unit is occurring? So as I said, there is a feedback loop. So you should be able to they should be able to know the muscle length, velocity, muscle tension, and joint position. This should be known. So how this is known is by a monosynaptic reflexes. Okay, and there will be control of the spinal and supraspinal polysynaptic activity from higher up. There will be control for this. So as you all know, there is extrafusal fibers and intrafusal fibers. Sorry.
Oh, I think you.
Okay.
Yeah, that's the mistake I was making.
Okay, there are extrafusal muscle fibers and intrafusal muscle fibers. This intrafusal muscle fibers are actually a sensory part. They are actually assessing the muscle length, fiber length. Okay, so when this is stretched, the efferents 1A and 2 fibers will be activated, and they will send signals to the spinal column. So actually, when the stretching of these fibers occur, what happens? The efferent fibers 1A and 2 will be sending to the spinal column, and the alpha motor neuron contracts, and that is how muscle contraction occurs. That is a simple stretch reflex. So there is another system known as gamma motor system. So there are two systems, alpha motor system and a gamma motor system. So gamma motor system is actually firing along with this alpha motor neuron, so that is known as co-activation. So that this spindle is kept taut. So when this spindle is lax, what happens? The information is not sent to the spinal column. So throughout the full range of motion, this spindle must be active or made taut by this gamma motor neuron. So when you are contracting your elbow, in the mid contraction, the muscle is contracting, that means the spindle is relaxed. So this spindle is made taut by this gamma motor neuron action. So afferent 1A and 2 fibers that will detect the rate of change of the muscle length. Then this is very important, the co-activation of the gamma motor neuron along with the alpha motor neuron. That is not co-activation. So Delisa has given us a very good example of a volleyball net. So actually what happens is that this is the, when the poles of this volleyball net are coming together, what happens? This net will become lax. So that is prevented by the gamma motor node activity. So if there was no gamma motor node activity, this spindle will be lax. So information cannot be passed to the spinal column. So this is a simple stretch reflex. So what happens is that when a stretch is applied, the muscle is stretched, then afferents from the muscle spindle, 1A and 2 afferents will go to the spinal cord and will comes as alpha motor neuron afferent, and it contracts the muscle. So this is a simple stretch reflex. So what happens when there is a simple stretch reflex means the muscle is contracted. Now further possible is not possible unless there is this Golgi tendon action. So what does Golgi tendons do is just it will inhibit the muscle antagonist muscle action somewhat, so that you can move your muscle. So it will produce a sealing effect for the muscle contraction. So it will produce a sealing action for the muscle contraction. So what happens is that when Golgi tendon, this 1B fibers fire, it will give an 1B interneurons, it is inhibitory interneurons to the agonist. So the agonist is inhibited, and it will give another one to the alpha, this one the antagonist, so that it will produce contraction of the antagonist. Then another one that is more important is the spinal interneurons. So these spinal interneurons play an important role. That is 1A and 1B interneurons. And there are the Renshaw cell and propriospinal interneurons. So what is the function of 1A and 1B interneurons and what is the function of Renshaw cell? So you can see here the Golgi tendon 1B, then there are interneurons, that is the 1B interneuron, that is inhibitory and facilitatory. So this is inhibitory to the alpha motor neuron for the agonist muscle. So that will inhibit the muscle contracting, and it is facilitatory to the alpha motor neuron to the antagonist. So it will produce contraction of the antagonist muscle and inhibition of the agonist muscle. Similarly, 1A interneuron. 1A interneuron, what will it do? It will produce facilitation of the alpha motor neuron and produce contraction of the agonist, and it will produce reciprocal inhibition of this antagonist. So what happens? This, as I said, the physiologists are the director has very well explained that higher centers are actually inhibitory. So when the higher centers inhibition is lost, what happens? This will co-contract, and antagonist muscle will co-contract with the agonist. So there is co-contraction. So this co-contraction is causing, this is a cause of spasticity. So in CP and all and cerebral origin spasticity, this co-contraction is an important factor. So that is facilitated by the interneurons. Then another one is the Renshaw cell inhibition. In Renshaw cell inhibition, what is happening is that the input is from the motor unit, motor alpha motor neuron itself. So that will go and this recharge cell will inhibit the agonist motor neuron and the motor neurons along with this other motor neurons also with the agonist. So it will inhibit the muscle, agonist muscle, and will produce, and it also through the interneurons, one interneurons it will produces the contraction of the antagonist. So this recharge cell action is mainly to produce a focused mode action. That is, it will give a precise movement to the muscle. So that is the action of the recharge cell. So recharge cell inhibition occurs in spinal cord injury. Then flexor withdrawal reflex, everything is as explained. So what happens when there is a noisy stimuli? You will try to flex your upper limb, lower limb. Okay. So after that there is a cross extensor reflex that will prevent you from falling down. That is extension of the other limb. And actually walking is also a reflex mechanism. You are giving some pressure to your dorsum of the foot, so that will produce an extensor thrust. So walking is also a reflex mechanism. Then the supraspinal influences that was also mentioned briefly earlier. So brainstem contains the neural circuitry for initiating locomotion, controlling the posture. Then this descending tracts, that is very important that you all should know. Actually, Sarah's also mentioned about the paraplegian flexion and paraplegian extension. That is an exam question. So which one is more important or which one is more deleterious to the patient? Actually, paraplegian flexion means that the injury is very severe. The spinal extensors such as the pontine reticulofunction and the lateral vestibulospinal tract are involved when there is paraplegian flexion, because these are the tracts, that is pontine reticulospinal and lateral vestibulospinal tracts are responsible for the extension of the limbs. So when the injury is very severe, when these tracts are very resilient to injury. So when this injury is very severe, this is called restriction of the pontine reticulospinal and this lateral vestibulospinal tract. Then it will produce paraplegian flexion, and it is very difficult to rehabilitate. Then, as you all know, this is a central pattern generator also. The spinal cord is not only a conduit, it is actually having so many other functions. As mentioned, that is a central pattern generator for it is capable of producing locomotory movements. So that is also used in rehabilitation. Now, how to manage spasticity? Spasticity is a syndrome of different components, including velocity-dependent increase in resistance to passive motion, involuntary muscle contraction, spasm, and hyperreflexia. So, what is the pathophysiology of spasticity? So, some say that it is mainly because of the intrinsic property of the muscle. Spasticity, you can explain everything spasticity due to this properties that is occurring in the muscle itself. Then another theory is that it is an alteration of the central. So, this is very important. This is necessary. Alternation of the central processing of the sensory input and to exclude structure in this muscle. So there should be some alternation in the central processing of the sensory input for spasticity to occur. So that is another theory. Then theory of gamma rigidity. This was earlier explained. So when this gamma motor neurons are overfiring, what happens? The 1A interneurons will be acting and the muscle will be contracting. So gamma rigidity was proposed as another explanation for this spasticity. But microneurography failed to demonstrate this. Then another explanation is that is a reciprocal inhibition, that is co-contraction, mediated through the 1A interneuron. So this requires facilitation from higher centers. So when that spinal cord is injured, this facilitation from higher center is lost. So there will be co-contraction of the agonist. So this is another mechanism for explanation of spasticity. Then another theory is the concept of an hyperexcitable motor neural pool. That is the reason one. A concept of hyperexcitable motor neural pool. Then other theories are central collateral sprouting, presynaptic disinhibition, denervation hypersensitivity, and neurotransmitters. So there are a lot of theories regarding the spasticity, and spasticity is one of the difficult things to manage. So actually what you are treating, spasticity means you are treating the muscle hyperactivity. So these are the components of the muscle hyperactivity. One is an abdominal stretch reflex. Then the efferent drives that are not totally dependent on the efferent feedback from the periphery. And disorders of the voluntary motor control, disorders of the voluntary muscle movement. So what does this mean? The efferent drives that are not totally dependent on the efferent feedback from the periphery. This means you have seen some CP patients and paraplegic severe patients walking, they are keeping their arms like this, going like when they are standing from the sitting position or doing transfers and all, they will just move like this. So this movement is not by it's not a reflex. Actually, it is an efferent drive that are not dependent on the efferent feedback. So it is mainly the muscles. It is going beyond the muscle stimulator. That stimulator that is known as efferent drive that are totally dependent on the efferent feedback of the patient. Then disorders of the voluntary muscle movement. So you should address all these things. You should address the spinal reflexes, hyperactive spinal reflexes, then this efferent drives, and the disorders of the voluntary muscle movement. That is when you are flexing your elbow, you are extending your elbow when the muscles of the elbow flexors are contracting. So this movement is not possible. So unless you knock down the movement in the elbow flexors, you are not able to produce movement in the extensors. Similarly, in dorsiflexors, when plantar flexors are not knocked down, the dorsiflexion may not be possible in some cases because the plantar flexors are overactive. So in such cases, you should give give Botox or something to reduce the efficacy of the plantar flexors. So this element you should know. So what is the cause for this spasticity you should know and you should treat accordingly. In the second case, if you are doing this one will second case when you are doing a dorsal rhizotomy, that will not affect this response because it is not dependent upon the efferent feedback. So if you are treating that, this will not be corrected. So and this is the important thing. Not all spasticity is dysfunctional. So lower respiratory tone may assist in sometimes the patient spasticity may assist in transfer, scanning, and ambulation. So don't knock down any spasticity. So if it is not affecting if it is not hindering the function of the patient, then only treat it. Otherwise, don't treat spasticity. So optimizing the primary function should be the primary outcome parameter in the treatment of spasticity. So specific impairments or functional deficits such as pain, problems with position, hygiene, or mobility. So these are the issues that should be addressed. So management principles. One is to reduce noxious stimuli. Second one is proper positioning. That is very important. Proper positioning of the patient is very important. Otherwise, it will cause contractures and other problems. Then serious stretching and casting. Then you can use physical modalities like cooling, heating. Then electrical stimulation. Electrical stimulation will reduce nociception, tension load. Then pharmacological treatments like benzodiazepines. They are mainly the GABA efferents. They demonstrate the effect to the GABA. So they act on the GABA A receptors. Then the baclofen mainly mean the GABA B. Attacks on the GABA B receptors. So you cannot. This is all written in the book. I am not going to explain all. So then the amberlin peripherally acting one. Then dose and all. Then tisanidine. So there are so many drugs. You know everything about the drugs for spasticity. Then nerve blocks, motor point blocks, phenol, Botox, everything. Then next topic. So I have given 2 topics and I don't know how to finish them.
Complete one. Complete one. Others they will read.
Okay.
Others they will read.
So because so pain. Then next problem. So you should manage to is the pain. So pain, there are 2 components for this pain. Pain. One is a nociceptive pain and another one is a neuropathic pain. So a newer one is that nociplastic is also there. So at least you should learn this also, these two. One is a nociceptive pain, and other is a neuropathic pain. So nociceptive pain means is mainly a musculoskeletal pain and visceral pain. These are the nociceptive. So nociceptive pain you can manage with NSAIDs and other modalities and all. And neuropathic pain doesn't NSAIDs don't work. So you should know what is the type of pain, whether it is neuropathic or a nociceptive. And the cause of nociceptive pain is mainly overuse syndromes, compression syndrome. In paraplegic patients, mainly the shoulder, rotator cuff injuries, tendinitis, bursitis, and carpal tunnel. So there are so many causes for this musculoskeletal pain. So you should know what is the pain generator, and you should treat accordingly. So that is important. Neuropathic pain also similarly there are the pain generators like peripheral, spinal, and supraspinal. So peripheral may be due to a compression of a nerve root or something like that. And spinal can be due to the injury to the spinal cord or some irritating lesion in the spinal cord. So by giving some anesthetic block, you can block that. And there is supraspinal. So actually supraspinal means thalamic and all. So actually this pain actually is having both the two components. Mainly a sensory component is there and an emotional component is there. So you should know about the pain pathway also. That is very important if you are going to treat pain, chronic pain or other nociceptive pain or neuropathic pain. You should know this pain pathway. So actually there are three. There is a transduction. That is, you are giving one form of energy is converted to another form of energy. That is a pressure or an chemical or thermal energy is converted to an electrical energy. That is action potential. That is known as transduction. Then there is transmission. So these impulses are transmitted through a dorsal bone. Then second order to the spinal cord to the thalamus, and from there to the premotor sensory cortex. That is for the sensory aspect of the pain. Then for the emotional aspect, so that is the perception of the pain. There is sensory cortex to the sensory aspect of the pain. Then the emotional to the limbic, to the periaqueductal gray matter, and to the reticulospinal tract, reticular activating system. So these all for the emotional aspect. And there is pain modulation also. Pain modulation from the periaqueductal gray matter. Then pain modulation is mainly by so your body itself having the pain modulation. That is serotonin and the noradrenaline. Okay, so that is the most powerful pain modulation. So what is happening this chronic pain actually is that this pain modulation is depleted. Mainly the serotonin and noradrenergic is depleted. So that is one of the reasons for the chronic pain. That is why when you are giving a small dose of amitriptyline or this one, what you call, when you are giving a small dose of amitriptyline, is actually not an antidepressant dose. You are giving a 10 milligram or 25 milligram. That is reducing pain not due to this antidepressant but due to this pain modulating effect. Where in a chronic pain, this serotonin and noradrenaline is depleted. So here it acts by noradrenaline and serotonin, and when it comes down, here there is the action by the opioids and this one, what you call that, cannabis and all will be acting is this level. And your gate control theory also is acting at this level. Okay, so you should know the pain pathway and how different drugs are acting in this pain pathway. Then only you can manage pain. That's very important. So you should know whether it is nociceptive pain or a neuropathic pain. This neuropathic pain, what is the cause, where the pain generator, then you should treat accordingly. So managing pain and spasticity, you should be thorough with your basics. That is very important. So thank you for the question here.
Thank you, sir.
Sir, please.
Take one more.
For a rehab expert,
This is a very interesting thing. As you are running your vehicle with a full kind of situation, you are in full control, you are energetic, you are enthusiastic about the future of the patient, and finally you find your tire is being punctured. So the situation becomes like doing rehabilitation, and suddenly you switch yourself to palliation. You are now maintaining the status quo. So when you talk about pressure injuries, here are some few things I would like to share with you. I joined PMR in 2008 under Dr. Joshi, and since then there are few minor changes in this pressure injury management. It's like वही होता था, वही होता है और वही होता रहेगा kind of situation. So with this situation, I would like to say हमारे टाइम पे सबसे बड़ा important factor था finance, not the availability of resources. When I joined as a PMR JR first year, we used to go and write mouth, bladder, bowel, skin care in each and every patient. We usually write facial range of motion. So with these kind of things, over the period of time, we have improved ourselves. And with the current financial status and the Chiranjeevi and Ayushman, each and everything, things are getting better. But still, there is a lacuna, and at the people who are actually the beneficiary of such kind of things are still lacking in that financial support. As it is a simple dressing by a compounder in a village, how much it costs in your area? Anyone can have an idea about it?
100?
Nothing less than 500.
I think Jitmer it is 100. In our area it is 300 to 500 rupees minimum. So if you consider 500 rupees a day, or maybe in 2 days, it's like say around 15,000 or say 10,000 rupees minimum at the end of the month. And that is a very good economical burden on this kind of patients, where you have already lost a few hope and then the things are like that. Definition, it is always, every time it is like that. We have just changed from National Pressure Injury Association, I just forgot, it's too boring to remember. Sorry about that. National Pressure Injury Advisory Panel. So, localized damage to skin and underlying soft tissues, usually overlying a bony prominence or caused by contact with a medical device or other object, which develop because of intense and prolonged pressure or pressure combined with shearing. Whenever you find a spinal cord injury patient, there is always associated trauma, which is of that magnitude that the impact has gone inside around say 6 inches and dislocated that vertebral column. So with that kind of thing, the risk groups are critically ill patients who are not moving at all, spinal cord injury patients who are again the same factors are there, receiving palliative care, obesity in the operating room. In the operating room, most of the times we find occipital ulcers, as the positioning of the patient is such that the pressure is at that particular point, we are not moving due to various intubation situations. What is the incidence and prevalences? Hospital acquired pressure shoulder injuries are 20 to 50%. As such kind of patients, the attendant says, हम घर तभी लेके जाएंगे जब ये पैदल चल के जाएगा. तो उस situation में एक तो initially the other departments are not very much fond of treating such cases, and to reduce the edema in the initial phase, they delay the procedures. So the patient is in the same position with same kind of restraints and everything. There will be a pressure sore associated with their pre-operative situation. There is significant loss of healthy life years, cost burden, as I told you. If you prevent by various means, you can save around 2.5 times of the total cost which you are inculcating in treating this condition. These are the common areas: occipital, scapular, as the most of the times patient is lying in supine position, and in sitting position, it is ischial tuberosity, then sacrum, then retractor. It's like say a D12 spinal cord injury patient comes to you and he is everything perfect, and then there is a pressure sore. what will be your plan? Are you going to continue with the wheelchair ambulation or you are going to stop it? Anyone? If I have a ischial tuberosity pressure sore, should I continue to ambulate in wheelchair or not? Then I have already booked myself, I was vocationally trained and I am going to the job with that wheelchair, doing household ambulation, which are the usual goals for us in a rehabilitation program. So in that situation, are you going to hold everything up and asking him to just lie prone in the bed? His earning source will be vanished, his quality of life will be hampered, his caregiver will be stressed. So it's a situation where you have to think of in a pros and cons type of manner. Me and Rudy sir have seen a case of meningomyelocele with a pressure sore and heel. He was working very fine. We asked him many times, chalna band karte, but he didn't stop. And हर बार उसको पट्टी करा के जाता था और 15 दिन बाद में फिर आता था कि दोबारा पट्टी कर दो. तो इस तरीके से people used to come and it's a more sort of a palliation, not a rehabilitation. So you cannot stop somebody who is already mobile and you should not stop by ethics also. What are the risk factors? You have to look for the nutritional status in BMI, microenvironmental factors. Is there are grievances or there are say some kind of bony prominences or some old fractures are already there, some callosities are there, or those things have to be taken care of. Many times using an orthotic device can lead to such kind of thing. Mechanical boundary conditions like using an orthosis, how much load you have put on that place and what are the shear ill-fitting kind of situation is there, then that will also lead to mechanical load. Or the person is also susceptible. You have seen people who have very thick and resistant skin, and others are very fragile and very parchment-like skin. So in those cases, you have to judge the person itself by himself. And whenever you find a pressure sore, it is always imperative to find out the basic risk factors, then you have to assess how much is the pressure sore. Various scales are there. We usually use an Orton or Braden scales, which Braden scale is including the points regarding activity, mobility, sensory perceptions, nutritional status, skin moisture, friction, and shear. If the score is more than 18, there is a high risk for creating an ulcer. This is still NP, IAP stages, stage 1 to 4, then unstageable covered by stuff or HR, and deep tissue pressure injury. Whenever you find a pressure sore, it's like say it never heals in terms of this staging. If a stage 4 ulcer is there, it recovers and now everything is fine, but still you consider it as stage 4 and it's better you write stage 4 heal in bracket. Officially, you cannot write heal also. Grade 1, erythema, non-branchable erythema of intact skin, discoloration of the skin, warmth, edema, induration, hardness may also be used as indicator, particularly of the individuals with darker skin. So, you cannot differentiate if a darker skin person is there, it looks like almost like a callus kind of situation, or sometimes symptom is underneath. You cannot identify. So, identifying stage 1 ulcer is very good. So, you can have a very peculiar look and you can see this if you have identified. Sometimes you find there are areas where there is no pressure, nothing else, but there is a same kind of picture. So in those conditions you have to find any allergic reaction to that place or any kind of say histamine release or creating environment is being there or not. Then only you go for this pressure, ulcer grade 1. Partial thickness skin loss involving the epidermis in grade 2 is there. The ulcer is superficial and present clinically as a abrasion or blister. Here you find the ash star and the superficial covering of the tissue. Usually blackened scar is there. After removing the ash scar or initial debridement, you will see this. Grade 3 or full thickness skin loss is there, involving damage to or necrosis of the subcutaneous tissue that may be extending down through but not through underlying fascia. Grade 3 and grade 4 are a little bit tricky. Grade 4 is all about, say, you are seeing the bone. Here you see, here we say this is unstageable. We remove it, we will find that this is grade 3 or grade 2. In case of, say, if the superficial layer is very thin, it is grade 2. If you have to find out the chunk and it is removed, there is underlying layer of fat is also there and it becomes a grade 3. These are the various methods. In our days, we used to just have a rough idea, scale in the eyes and just measure it. But the actual way you have to do it is by taking either manually by length and width of the wound, ruler method, tracing the circumference of the wound onto transparent acetate film. Why acetate? Why acetate? Can anybody answer? Most common hospital-acquired infections on the pressure ulcer when you assess are pseudomonas and Klebsiella. And having acetate at that place reduces their chances of getting the wound infected. Digital photograph and tracing the wound circumference and computer-assisted perimetry are there. Again, a few other methods like, say, you can fill the wound cavity with water and check the assessment. The other method we used to use in our days was, like, say, if we have pockets, we used to fill the pocket with the gauze piece. Fill it up and how many gauze pieces are there inside the room. Those are there. For seeing the progression of the disease, say pressure sore, spinal cord impairment, pressure ulcer monitoring tool, SCI TUMT 226 score is high and severe. It is basically developed for spinal cord injury and validated. Another scale is Batts and Jensen wound assessment tool. Pressure ulcer scale for healing. Push scale is usually used in the routine practice. Another one is the pressure sore status tool. Now, whatever the things are, systematic and holistic approach to wound evaluation and treatment, major aspects of wound care are timers. Management of non-viable deficient tissue, infection, inflammation control, moisture imbalance, epithelial advancement, repair, regeneration, and social factors. Here, all things are there. Social factors are very important. I have seen cases 6-year-old GMFGS 5 kind of CP patients, or say spinal cord injury, let's say D6 complete. They hardly have any ulcers. And the other cases where D12 or L2 is there, and you will find many ulcers in them. We usually, on the third Thursday of November month, we usually have this worldwide pressure injury prevention day. So this is another aspect of creating public awareness. Patient education is very important. It has a personal impact on the pressure sore injury and quality of life. We have to stimulate or say initiate an approach of the person with pressure injury, that how he is going to take care of his own wounds. We have to talk about the risk factor education, positioning and equipment, complications and how to prevent, daily skin care, wound management, and when to seek medical care. So there is a very important rule, repositioning rule. You ask the patient to tilt himself to 30 degrees by somebody's help on, say, left, then come back on the right, then come back. We usually write 2-hourly turning. So that 2-hourly turning is 30 degree tilting on left and right side with stay in between again for half an hour or say 2 hours. In the night, that 30 degree becomes 90 degree. In the night, you tilt yourself on the half side and then move accordingly. These are the various types of mattresses available. Some are active mattresses, others are reactive mattresses. Active mattresses are powered ones. They are unable to. They are used in patients who are unable to reposition themselves, or with the incident or worsening pressure sore injuries. They dynamically redistribute pressure. Low air loss mattresses and air fluidized beds are in this category. The other foam, gel, water or air mattresses are powered or non-powered kind of reactive mattresses. They are used in stable spine who can reposition themselves. with no active pressure, or the person may be with no active pressure injury or grade 1 or grade 2 healing pressure sore injury. Here are the few pictures of low air floors and air fluidized beds. Those are very costly. A single this kind of bed will cost you around, say, a mattress will cost you around, say, 13 to 15,000 rupees minimum. These are the wheelchair sitting system. The most important thing is we don't use, say, donut cushion in, say, Kottayam and everything. You have heard of that. Donut cushion is very important. Even in those cases who have a resistant type of Kottayam, you will see the patient will complain that when I sit on this cushion for, say, 2 hours, my ischial tuberosity starts paining, and the SCI joints also cause pain. So the donut is not the answer. You have to look for the heat. Basic again, pressure relieving by lifting himself from the cushion is the most important aspect. We have to take care of the skin. There should be no wrinkles in the bed sheet. Systematic skin inspection twice a day with long-handled mirrors and skin side cameras, and frequent cleaning with soap and water. Here, frequent cleaning means not more less than 12 hours. ऐसा नहीं है हर 2 घंटे में धोए आप उसको. Moisturizer and emollients not recommended, but usually they are used. We avoid talcum powder basically. In, say, supine position, the head end should not be more than 30 degree tilted. If that is lifted, then there will be traction or shear forces on the skin. In prone position, standard surface, we use bridging technique, and fluidized mattress without bridging it can be used. 30 degree lateral positioning can be done in, say, as I have discussed with, say, repositioning rule of 30. While using your this wheelchair, you can relieve the pressure every 15 to 30 minutes or 2 minutes. Here there are few important things. If the pressure sore is clean, everything is fine, you don't have to add any kind of nutrition and the person is healthy. If it is not so, you have to take care of the calories, 30 to 35 kilocalories per kg body weight. Protein should be recommendation for a healthy male with a sedentary lifestyle. How much protein is needed? 0.8 to 1.5 gram is the range as per his activity. So here it is 1.25 gram to 1.5 gram. As we think that there is a loss of protein from the side of the pressure sore. Water 1 ml per kilocalorie, it's 40 ml approximately per kg body weight. Here are the culprits which gives you an idea that pressure sore is healing. But actually there is a thin film. Main culprits are as usual pseudomonas and Klebsiella and Proteus. So they make a matrix on the wound, and that allows the bacteria to remain hidden and safe from the antibiotics which you are using topically. So in such cases, cleaning that wound and the granulation tissue is very important. To manage a pressure sore, we start in a methodical manner. So first of all, hemoglobin for wound healing should be more than 10. ELC count should be less than 10,000. ESR and CRP should not be more than 30-35. CRP around 5 or 6 or not more than that. LFT, pre-albumin we usually don't do. Total albumin count is needed. Creatinine and blood urea nitrogen is also very important indicator of dehydration or the proper functioning of the kidney in the patient. Pus culture from the swab, usually it is not recommended when the clinically person is not symptomatic. But whenever a patient comes to a hospital, we usually try to have a single baseline assessment that any kind of bacteria is there. So first, whenever he gets symptomatic, then we have already a sensitivity list from where you can choose an antibiotic. X-ray of pelvis, sacrum, and greater torpedo are needed. You have tried your basics, and these are the various ways of say. Now the answer is there. How you are going to treat it? Either you apply the enzymatic preparations, either you do autolytic debridement, you go with the mechanical debridement and the surgical fractions. Enzymatic preparations are there, collagenase and peptinuria. They selective in deactivating by transition metals, and they are slow and costly, usually used in grade 2 kind of situations. Autolytic dressings have hydrogels, hypertonic saline and lactospermum honey. These are selective and non-invasive and slow perimount maceration are the side effects of these conditions. Wet to dry, pulsatile lavage, hydrotherapy, debridement pads and ultrasonic debriders are also used. They are non-selective and macroscopic, and they can be used bedside and are rapidly clear the wound. When you say the wound is clean, when you see punctate arterial bleed or the bed is pink. This is again a very awful situation in first year of our lives. When I see first time maggots in a wound, I was horrified what is happening. And then my senior came to me and said, कोई बात नहीं होता है, अच्छा है ये हो रहा है तो ये भी एक तरीके का debridement हो रहा है. So that attitude, but those were different kind of bacteria or larva, and we used turpentine oil to remove them. And then we have done debridement, and we have done an excessive kind of say debridement, and for that we have to think of कि अब कौन डांटने वाला है. तो इस तरीके से we have started with this maggot debridement therapy. We occlude with say a net kind of things, these kind of larva in that, and for 48 to 72 hours, and then remove it. No this betadine or any spirit is used to clear the margin or anything. You just clean the whole wound with the normal saline and then apply these things. So when we think that infection is getting spread due to this, at local level, you see that there is a redness of the wound which is getting increased. It is giving a picture of cellulitis, or say in 25, it is not healing, so there may be underlying osteomyelitis. Systemic infection is presented with fever with leukocytes, increased exudate size, undermining friable granulation tissue, abscess formation, malodor, wound bed discoloration, and tissue grafts. Here, most of the condition when osteomyelitis is present, it is almost irreplaceable. You cannot remove the, as you say, the bony spicules are there on palpation and you just remove them. It is not like that. It is like the wound is not healing at all, and you cannot compromise the bone also. So you just go local patching with say gentamicin or give intra-IV antibiotics. So you cover that with that thing and hope that the thing will recover on its own. As I said that routine wound swab is not recommended, but we used to follow this practice, and topical antibiotics in non-infected PRI is not recommended. These are the basic differences in antiseptics and antibiotics. There is a broad basic thing is antibiotics are less toxic than antiseptics. That's why they are not used as a IV or in these kind of. There are various dressings, alginates, transparent films, hydrocolloids. You will get all these things in a proper way, and if you speak about 2 to 3 lines in your viva, that will be giving the sufficient amount, as I think 90% of the institutes are not using them. Most important thing is this impregnated gauze. This is the cheapest one, can be given to the patient to be used at home, or the patient can autoclave his gauzes at home. He can use to increase the granulation by using phenytoin in this. You can use this to remove this Pseudomonas or Klebsiella by dipping it in an acetic acid solution. You can use this gauze as a dry gauze to mechanically debride the wound. It is the easiest and cheapest way. Or you can simply put a normal saline dipped gauze to improve the healing of that wound. Foams are also available, hydrofibers are also available. Do you know this this alginate? What is this alginate?
Ravi, 1 minute Ravi.
अच्छी बात है. What is alginate? It's derived from the algae. So it's an extract, alkaline extract, which is used to heal the wounds. So this is the basic dressing. How you are going to dress? Optimize the wound. Optimize by meaning of say metabolic regions. Then you check it is infected or not. If the amount of exudate is very low, then use silver, honey, and foam. If some exudate is there, then these things will be used and copious. And NPWT is very important in those cases. And you have to look for that. Those should not be very close to larger arteries or some kind of say coagulopathy should not be there. This is another very cheap and very resourceful kind of thing. Parenteral solution can be used, and we have used in a very good manner in this. Surgical management, not everywhere this is happening, but I have seen many with my teacher, and initially even I named them incorrectly. Then he said I should go and read Graph's atlas regarding this. Few centers, one of there is AIIMS Patna, where I think these things are being dealt with.
Over. Right.
In our PGs. It's related to emergencies related to SCI patient. Before that, may I just take some feedback on the PGs? How many of you have actually faced emergencies? You have said it. It's a team approach. So immediately when there is emergency in the ward, first thing, ask for help. Immediately, that is the only condition. Use your mobile phone or any phone to inform the emergency team that there is an emergency. Then immediately, what's the next step? Next step is put to access. Immediately, check it. Is there any access? Because whoever may be the expert in this field can't do anything if there is no access. So ensure access first. And then immediately ask for the defibrillator machine and emergency trolley. That is another important issue. Never forget that you are probably going to deal with that ensure patient safety and your safety also. That is applicable in any emergency condition, including the spinal cord emergency. But interestingly, patient generally becomes critical all of a sudden rarely. That is the trick. Most often, patient becomes sick within 24 hours to 48 hours time. So, if we closely observe the patient, then probably we will get the time to prevent the emergencies. But if there is a sudden onset problem, a cardiac arrest, then definitely we need to start advanced life support. We have to start BLS immediately. So we should be comfortable with BLS. Immediately we need to shout for help, activate the emergency response system and get AED. Look for, is there any breathing, only gasping, or check the pulse also. When there is a normal breathing and pulse fair, then only monitoring until emergency responder arises. When there is no normal breathing, but pulse fair, then provide rescue breathing. 1 breath in every 6 seconds or 10 breaths per minute, and check pulse in every 2 minutes. If no pulse, then start CPR. But whenever there is no breathing or only gasping, then pulse is not felt also, then start CPR without wasting any time. Pop-up cycles, you know that it's a 30 compression to ratio, and use AED as soon as available. AED is the external defibrillator. Check it with this rhythm, AED, that is this patient, is this condition is shockable or not shockable. If it is shockable, shock it. Give 1 shock, resume CPR immediately for 2 minutes, and continue the ALS until it's over. The victim starts to So the victim starts to move. When it is non-shockable, then continue the CPR 2 minutes, then get the rhythm again, and then continue it in that way. And I will suggest all the PGs, please train yourself with ALS also. Because in current day practice, I think everybody should be aware and expert, at least know the advanced life support. But interestingly, most of the patients deteriorates over 24 to 40%. And in that context, some of the scale are really helpful, like modified early warning MUSE score. It's widely used everywhere. And a doctor doesn't need to do it. Nursing staff, anybody can perform this simple scoring system, and I'm sure that you know that scoring system. That when the score is 0 to 1, then we can just monitor the patient. When the score is 2 to 4, then patient should be closely monitored under that specialist team, but that monitoring should be, that evaluation of MUSE score should be done every 2 to 8 hours time. When it is more than 5, then chances of death or critically ill situation will be very, very high. So always send the patient to ITU or ICU or any acute setup. So that is the score I think we can easily follow. And also NHS just changed this little bit with news. In pediatric also, this score is used as PUSE. So what are the common sudden emergencies which are related in SCI? We know we have discussed about AD and we have discussed about PE. So in the morning, there are a lot of discussion about AD. It is commonest in first year of injury. We know that if you get a call, that some patient becomes sick, SCI patient with a severe headache, blood vision, sense of impending doom. Then the issue is that definitely you check the blood pressure. And here again, if you think about the MUSE score, then you can check that in MUSE also the common thing, like when you are seeing the pattern, when the blood pressure is going up, so hypertension, sudden hypertension is most often due to AD. Unless there is some other acute cardiac event is going on. Otherwise, most of the cases you get hypotension. Hypertension with bradycardia, so it's probably AD. But sometimes hypertension is bradycardia, but hypotension with bradycardia, probably it's something related with bradyarrhythmia. If it is a hypertension with tachycardia, so most likely it's a case of patient is going into shock. It may be different type of shock. So when there is a hypertension with tachycardia and there is a hypoxia, or the patient hypoxic or not, if the patient is hypoxic, then probably the cause is pulmonary cause. So if the patient is hypoxic with hypocapnic, then probably the chances of pulmonary embolism is high. If the patient is hypoxic and hypercapnic and the patient is going to shock, then probably there is some aspiration, some blockage is going on with the patient. So it's simply checking this pattern of MUSE score, you can also predict that probably the patient is suffering from this type of problem. Question is that why AD, we are discussing about AD, why this type of symptoms, why we are going to treat the patient in this manner in case of AD. This is just because of simple neurological connection. We know the anatomy of sympathetic chain, we know where the parasympathetic inhibition is coming up. So it is this area where actually the celiac ganglion, this splanchnic circulation control is going on from the sympathetic system, from this T5, T6 area to this area. So whenever there is some stimulation is going on under this level, suddenly the sympathetic system is going to be stimulated. And the parasympathetic, this baroreceptor in the heart, this is baroreflex is going to be stimulated. So due to this sympathetic overstimulation, due to the stimulation of the adrenal medulla, there is a vasoconstriction and hypertension. All the symptoms of hypertension, diaphoresis, all the symptoms of hypersympathetic state are going on due to this thing. But interestingly, after stimulation of this baroreceptor, with this baroreceptor mediated bradycardia is going on, then there is some parasympathetic inhibition is supposed to come over there, but it is not coming. It has been disconnected due to spinal cord injury at that level. So that's why there is a continuous sympathomimetic effect is going on. So this is the simple mechanism. So the only thing is that if we can only eliminate this stimulation somewhere below this level, then only the whole cycle can be controlled. Meanwhile, we have to control the response of hypersympathetic state. And whenever this elimination of this thing will be done, immediately the whole hypertension and everything will calm down. But the problem is that if you give some antihypertensive of some other medication which holds actually action, duration of action is longer, then patient may become hypotensive after the elimination of this problem. So that's why we need to treat AD, because to prevent the complication of AD, we know that seizure, retinal hemorrhage and other renal insufficiency, lot of other organ damage may happen due to AD. So we all know that elimination of the trigger factor is the main thing, but some of the medications are very, very effective, which generally most recommended is that if we can use GTM spray, laser spray, but because the action you can see here, but nitroglycerin, it's 1 to 3 minutes is sublingual, so action of duration, onset of action is quite low. Otherwise, we can use nifedipine, it is freely available, sublingual. But captopril, these are not freely available. There are some issues regarding use of IV labetalol, because labetalol is available in institution. But the problem with labetalol, there is some literature nowadays that it may further deteriorate the bradycardia, because that is the only issue with the labetalol. Then, when you think about pulmonary embolism, we are talking about pulmonary embolism, PE. When I have some experiences in working in NHS, the actual incidence of PE is very, very high in NHS in other setup, but we are getting lesser and lesser PE in our setup. Then why? I'm sure that patient is suffering from PE, but we are missing it because probably we are not properly probably following the guideline. We know the symptoms, we know the signs of mild PE, moderate PE, and severe PE. But where may be the problem? And we know that in PE, we will get a respiratory alkalosis with hypoxia and hypocapnia. But the problem is that, and we know also that there may be classical well-shaped lesion in chest X-ray, and in CT also there may be just, can you see this ring? This is polomid sign. This is the polomid sign. So we know all these features, and we know that in ECG there may be S1, Q3, T3 distribution, that is S1 in lead 1, and in lead 3 there is a Q and there is inversion of the T. So that is S1, Q3, T3, but probably we are not always following the scoring or guideline. In well score you can see any patient maybe tachycardic, maybe hypoxic, but very important thing that is this patient is having clinical signs or symptoms of DVT, that we are checking, then the patient will get 3 points. But another very important thing, that do you have any alternative diagnosis of that condition? If there is no alternative diagnosis, then the patient will get 3 points. I think most often we are missing this thing, then probably we are missing the whole picture of PE. Because if the patient scored more than 4, then PE is likely. So if there is no alternative diagnosis with a suspicion, then also the patient will get 3. And then if the patient is tachycardic, then the patient will get 1.5. So patient will be a suspected case of PE. So we have to treat with a strong suspicion. We should not miss any single PE. So any suspected PE, this basic 3 examination, vital signs, ECG, Q3, T3, and this ABG, the respiratory alkalosis with hypoxia and hypocapnia, then we should start the supportive treatment immediately. If the patient is hemodynamically stable, then we need to check it. What about the systolic blood pressure? If the systolic blood pressure is more than 90, then we need to check well score. If the well score more than 4, immediately start with anticoagulation with low molecular weight heparin, 40 milligram twice daily, and then if the patient is actually unstable or if the well score is less than 4, then we can wait for the D-dimer, and then we need to exclude P in that way. But when the patient is unstable, systolic blood pressure is less than 90, then we need to start resuscitation. And patient when is not enough for stable for CTPA, then there is a role of echo. So we need to check right ventricular dysfunction, or otherwise no right ventricular dysfunction, we need to exclude of fulminant P by further diagnostic. But I have seen in our setup also, in not many situations, echo has been prescribed or suggested. But the role of echo is here only. But when the well score has a tremendous role when the patient is much more stable. So never forget this criteria. And then whenever with the starting of low molecular weight heparin, the patient is stable, continue low molecular weight heparin for 5 days. We need to immediately start warfarin. So target INR is more than 2.5, and whenever the patient will reach the target INR, we need to stop the low molecular weight heparin. We need to continue the warfarin. General trend in adult population, it's better to go for 10, 10, 5. Day 1, 10 milligram, day 2, 10 milligram, day 4 is 5 milligram. If the patient is renal or hepatic compromise is there, then reduce the dose to 50% and that try to attain the INR and continue with the dose and then monitor the INR. Then twice weekly, alternate day, followed by twice weekly, then weekly basis. And probably we need to continue the whole anticoagulation for at least 6 months time. When the patient is hemodynamic unstable, then consider RTPA therapy. And when there is bleeding is high or poor clinical response to RTPA, then only we need to consider surgical embolectomy. What about the other respiratory emergencies which may happen in high cervical SCI? This is another important issue, this accidental tracheostomy tube decannulation. This event can be life-threatening, particularly if it occurs before the tract between the skin and trachea is fully matured within 1 week. This is emergency management needed, that is we need to ensure the adequate oxygenation, we need to check the duration. If it occurs within 1 week of tracheostomy placement, then stomach tract is immature and high risk of creating a false passage into the mediastinum, so there is a chances to develop mediastinitis or even pneumomediastinum. So try to avoid this thing. When it is less than 2 weeks time, then surgical consultation, re-entry through the previous site if immediate tracheostomy fails. If it is more than 1 month, then chance of misplacement is low. Only oxygenation is maybe the issues. And another thing is that tracheostomy obstruction, which we generally use quite often, is caused by various factors, maybe due to mucus plug, maybe due to thick secretion, granulation tissue, blood clots, kinking of the tube itself, so foreign objects. So immediately perform a ventilation assisted measure such as head tilt, chin lift. Simple measures, just head tilt, chin lift. Then it may help. Symptoms ranging from mild shortness of breath to complete respiratory arrest depending on the severity of the obstruction. So speaking valve should be removed or the cup should be deflated. And attempt to pass a suction catheter through the tracheostomy tube to just get rid of the blockage. If it is a mucus plugging, then it is sufficient. If the suction catheter can be passed beyond the distal tip of the tracheostomy tube, that is at least 10 centimeter, then the patient's oxygenation and ventilation should be re-evaluated to ensure the proper functioning of the tracheostomy tube. So tracheostomy blockage, that is another issue, we need to shut it out. Gradually deteriorating state, it's very crucial to pick it out. If we miss it or untreated then overlook, then the patient is going to in shock most of the situation. So clinical features of shock, we know that patient's mental status should be altered and urine output should be low, blood pressure, systolic blood pressure less than 90, mean arterial pressure less than 60, metabolic profile is lactic acidosis with metabolic acidosis. So we need 3 things: change the blood, check the blood pressure, check the urine output, and do an ABG to establish the diagnosis of shock. Or if we miss this shock event, then probably the patient is going to cardiac arrest. So we are going to landing up a more difficult situation. So what are the important management issues in shock? We know that we need to ensure the airways. And again, IV access is very, very important. Sometimes it may be inaccessible. But nowadays, all of our PGs are quite competent with USG. And it is quite easy to go for a central line with USG. You can easily, if you put the probe there, you can see the vein quite easily. And then you can put the needle there, the gel there, and then read the central line there. So it's not that much difficult. So in shock, whenever the patient is shocked, then next the question is that which type of shock is this? Is it anaphylactic shock, septicemic, cardiogenic, or hemorrhagic shock? Hemorrhagic shock is very, very unlikely in the setup of rehab setup in SCI ward. Anaphylactic shock can happen. Cardiogenic shock, though, is again unlikely, though there is some literature is coming out that dyslipidemia is a fact, it may happen in chronic SCI situation, but until and unless it's an aged patient, unlikely to be a cardiogenic shock, most likely it is septicemic shock. So in shock, we have to ensure the fluid, we need to ensure the vasopressure. So which vasopressure? That is the question. Is it NORAD, adrenaline? Which vasopressure or dopamine? Very simple solution. Start NORAD in any septicemic or neurogenic shock, suspected neurogenic shock. We know if it is anaphylaxis, it's adrenaline. If it is a cardiogenic shock, it's dopamine. We need to start at lower doses, then to top it up. But in case of phenylephrine, there is a difficulty is reflex bradycardia. And again, before confirming that it's a septicemic shock, we need to follow the SARS criteria. The patient should meet at least 2 or more criteria. Temperature must be less than 36 degree or more than 38 degree. Should have been tachycardic, tachyptic, and the WBC count either may be less than 4,000 or 11,000. Or Q-SUPER criteria should be fulfilled. At least meet 2 or more criteria. Respiratory rate more than 22, alternate mental status, and systolic blood pressure is less than 100. So when we confirm with this criteria that this patient is suffering from septicemic shock, then the very important issue is the patient is suffering from euvolemic shock or hypovolemic shock. That is very, very important regarding fluid management issues. And fluid response, how much should we go for this fluid challenge? It should be 90%, because fluid response is 90% of organ perfusion, 10% due to nutrition. Sometimes it's very, very difficult in this type of condition when there's an elderly patient who is suffering from shock, that the patient is septicemic, a hypovolemic or euvolemic shock. Again, ultrasound is very, very helpful in this situation. You people are very good with ultrasound. Just put the probe on the IVC. Check it. That is that IVC collapsing or not. If the collapse of IVC is more than 50%, then you will be sure enough that this is hypovolemic shock. So you will be liberal to give lot of fluid challenge to that patient. If the IVC collapse is not there, be very cautious to give lot of fluid, because it may land up with heart failure. So in septicemic shock, organ dysfunction to be proven, it must be proved in current day situation. Then next question is that after reperfusion, after vasopressure, elevation of the blood pressure, next issue is that we have to target the culprit. Then which culprit we are targeting? There may be 3 sorts. Either it is infected procession, or it may be an infected bladder, or it may be a respiratory thing. Most often these are the 3 culprit areas. If it is a pulmonary areas, if it is a pressure shock, that most target, if it is a hospital-acquired infection, target MRSA. If it is a bladder, then in hospital-acquired setting, target ESBL current day practice. So the recommendation is that MRSA, linezolid or vancomycin, it is preferred. If it is a ESBL, we have to go for it is piperacillin tazobactam or any type of it. So that is the recommendation to start with the full dose. Never compromise with the bolus dose, full dose. There is no meaning to give a restricted dose. If it is a hospital admission with respiratory infection, particularly respiration, sevoflurane sulbactam is a good combination to start with, because it is a very good anaerobic coverage also. And in home also, most communities source this aspiration. So in this way, we need to target. But last little thing, that try to avoid fluoroquinolones. Sometimes we have a tendency to start fluoroquinolones, but as per guideline, it's better to avoid fluoroquinolones. Next is that anaphylactic shock.
Sir,
2 minutes. Anaphylactic shock, never in anaphylaxis in any situation. Always avoid the trigger point, start adrenaline, and then take the offending agent out. and then you can get rid of the anatomic tissue. Then be very, very comfortable with the assessment of ABG that I'm seeing. If we can discuss later on about ABG itself, that ABG assessment is nowadays is essential component, because if it is very simple. Look for pH. If the pH is low, it's acidemia. Then check it is high. What about the PCO? If it is high, respiratory acidosis, low, the bicarbonate metabolic acidosis. So then it may be compensated with the other ways. Same thing happens in albuminemia also. So, and never miss to look for lactate to check for the tissue perfusion. And in metabolic acidosis, in this context is very important in septicemia, and respiratory alkalosis is very important in context of pulmonary embolism. This electrolytemia, I'm just going to focus on only one slide, because hyponatremia you have a tendency to treat with lot of drugs and 3% magnesium. But in SCI there is enough recommendation that hyponatremia can happen due to the changes of the extravascular phases. So we have to wait until unless symptomatic we should have treated. If it is less than 115, then only we can think about to go for 3% in SCI. If to check about is there chances of development of hyponatremia. Even longer term, we need to be very careful about hyponatremia and hypokalemia. I'm not going into the details. So thank you so much for your patient sharing. It's a little bit bigger topic. Thank you for finishing here. Thank you.
Sir, please.